Good morning. I hate to rush everybody, but we do need to take our seats and get started. My name is Trilby DeYoung, and I am the CEO of the Finger Lakes Health Systems Agency. And it's really my pleasure to welcome all of you here this morning for this really unique opportunity to hear from a thought leader and a pioneer in geriatric care. Very excited about what we're going to get to share this morning. Jennie Hansen is going to talk to us about who and how we will address the needs of our aging population. This is really a pivotal issue in our region. Last July, the Finger Lakes Health Systems Agency released a blueprint from the Regional Commission on Community Health Improvement. And that was a group that brought together over 150 different experts in our region to talk about how do we improve care, looking at prevention and public health, behavioral health, and senior care. And what emerged as an issue across all of those areas was workforce. It's really a critical foundational issue that we must address if we're to make progress in improving health. And so we formed a consortium, a regional consortium on healthcare workforce. And we brought together leaders, CEOs from our major healthcare employers, our educational institutions, insurers, payers, and consumers. And we have sat together once now to begin to talk about how we might reach some common ground on the priorities for our healthcare workforce and the key components that our educational institutions need to address to prepare people for these new roles and the emerging technology. So I can't think of a better time to hear about what's facing us with our aging population than now. And I'm very grateful to Louise Warner, a member of our consortium, who brought Jennie Hansen to us as a recommendation for somebody who can help advance our thinking about what we're going to need to do. So it's my pleasure this morning to introduce to you Louise Warner, who will then introduce our speaker. I have actually a single-spaced page of the different awards and recognitions that Louise Warner has received throughout her career. And Louise made me promise not to read it, which is very difficult because in going through it, I was so impressed with all that she has accomplished and how much she has been recognized, not just for the leadership in healthcare and nursing, but in workforce and economic development. In our region, as the founder of HCR Home Care that serves 23 upstate counties and employs over 750 people statewide. So not only her leadership here in upstate New York, but across the country and internationally. And truly, the list of honors and awards is incredibly impressive. So we're so fortunate to have her here in this community, serving as a mentor to many of us and helping us recognize the critical issues and hear from thought leaders from around the country. So thank you so much, Louise, for bringing us this recommendation.
Thank you very much, Trilby. When Trilby asked me about potential speakers to help advance the Workforce Consortium's thinking about how we understand future models of care and what that impact on workforce is going to be, there was only one person that came to mind, and that was Jennie Hansen. And the reason that I thought of her was not because she's the child of Chinese immigrants who was widowed at age 28 as a single parent who had to take care of her aging parents, and also not because in 2015 she was named one of the top influencers in aging by the public broadcast system, or because she's the American Society of Aging's Hall of Fame, but because of all of the experts that I know, she's the one who has the most breadth and depth across all the issues that we have to think about in the Workforce Consortium about aging in our community and our country. On the issue of policy, Jennie Hansen is a leader and an expert in public policy. She was a founder and top executive of a program in San Francisco that became the Nursing Home Without Walls. It was a started at humble beginnings 1971 as a daycare program. And then with Jennie's leadership as 11 years as their CEO, she was enabled that to get enacted into federal law in 1997 as the PACE program. And now that's in 30 states, and as you know, we have one of them here in Rochester. So public policy, Jennie Chen Hansen is an expert, and that's only one of the public policy areas she knows about. The customer perspective is also critically important in workforce. Jennie has served as the president of AARP. That organization has 38 million members who are very concerned about aging issues and what the workforce will that be. And what I thought was important among the many accomplishments she had as the AARP president, she promoted an idea called caring conversations, where she encouraged families to get together to talk about how they would deal with aging. Of course, one of the most important things, although the one that's hard to think about, is payments. And Jennie has been a federal commissioner on MedPAC. You probably know that that's the Medicare Payment Advisory Commission that was enacted in Congress, part of the Balanced Budget Act, 1997, where there was a special board set up to decide what payments Medicare would make to providers and to insurance plans. I think Dr. Bill Hall is now serving on that committee as well. And then what are the providers, the real people doing the workforce, various aspects of care? And she was president of the CEO of the American Geriatrics Society. That's an organization of about 6,000 interdisciplinary providers who are working to make sure that the complex care needs of older adults are met. So as you can see, for those reasons, when we need to think about workforce issues, there's no one better than Jennie Chen Hansen to do that. She's now back in San Francisco. She's acting as a senior advisor to the American Geriatrics Society. She's also on the board of several startups, and I'm very pleased to call her my friend. Jennie.
Well, thank you, Trilby, for this transition. And Louise, thank you so much for thinking about me, for being a part of this morning with you. And many of you know Louise, obviously having been a part of this community and continues to support and invest it. It's an incredible area of leadership that you've provided, not only, as we said, nationally and internationally, but so important in your own home. So I've actually come to Rochester now twice because of Louise and the kind of commitment that she has for the community here. So I really appreciate the fact that there are a number of my colleagues here. Actually, Dr. Annie Medina Walpole is here, who heads up the geriatric division at the University of Rochester and was actually my boss because she was on the board of directors of the American Geriatric Society when I was working there as its CEO. And many of you also know Dr. Dan Mendelson, who is connected to the program and has actually, I'll bring it up a little bit later, but is an innovator in his own right relative to the whole area of geriatrics and orthopedics. And then I would be sorely remiss if I would not acknowledge Dr. Bill Hall, who actually drove me here this morning from my hotel, but I have had a chance to know him from his early support of the PACE days. And in particular, he and I served on the board of AARP at a similar time, and I'm absolutely delighted that he is now a commissioner on the Medicare Payment Advisory Commission that Louise also mentioned. So I have some good connections here in Rochester, not the least of which that my son checked out the medical school when he came. He had the misfortune being a California boy coming here in midwinter and decided, I don't think so. So he's a little bit soft, so he stayed in California. So, probably my biggest acknowledgement, which precedes a lot of my work here, is to Dr. T. Franklin Williams. And Dr. Williams was a person of huge stature here, but many of you don't realize how important he was to the beginning of the work that we did in San Francisco at Unlock. He courageously came out and supported the PACE program. It was not known by that name at that point. It was still our Unlock Senior Health Services program in San Francisco. But he saw something, and you know he always had a twinkle in his eye, but he also had an intellectual twinkle in his eye about what was going to be possible. He stepped out amongst his colleagues in medicine to really support this model at a time, I would say 30 years ago, before people took note. In fact, we're beginning to complain about it. And so that's one of the aspects of leadership and courage, and being able to see beyond the boundaries of that which exists. And that's part of the premise of my conversation with you today. I'll be having a chance to really think about, what is it that we're really trying to achieve, and what are the facts that are there in place, and what are the facts that we have made happen, in some ways codified as human beings, but have an opportunity now to really think and step back again, and what else can be done, because as we'll see, and you all know, the math doesn't work. In terms of the way the workforce is. The fact that you had the forethought to really bring together your region in this way, to think about who will be the workforce, not only for older people, but frankly, the whole healthcare infrastructure is fairly fragile when it comes to thinking about who will support this. So it's a fantastic time, again, for some risk-taking, some innovation, and the ability to, for a moment, suspend that which we know and think about what we are geared to try to achieve. So with that, let me move to our presentation. And one of the things that we've heard about tremendously, and I know this audience here is well attuned to the triple aim. One of the things I did was to take apart that triple aim and really think about it relative to an older population. And incidentally, workforce in some ways is actually the fourth aim now. They've been talking about it's actually a quadruple aim, and that is making sure that our workforce is fully available and engaged. But I have three circles here. And one of the things that I look at relative to thinking about an older adult, when we talk about the three core areas of better health, better care, and more value or lower costs, when we think about the pink circle, this is what older people really want, any of us want, and that is better health. And the words underneath say, the fact that they want to be able to live their lives, they want to function, they want to be in their communities. So that's really what the big circle is about. In the middle is better care, and those of us who've been in the healthcare field really talk about quality and safety. We talk about transitions of care. We talk about how do we be compassionate at the same time as engaging the public in making sure that people understand the decisions that they have, that they can make. And then the whole area of greater value, lower costs. And the whole intent there is the fact that we, those of us who are employed, we watch our premiums going up. As consumers, the amount of money that we're spending in this day and age, not only for our premiums, but for our co-pays and deductibles, affect us on a consumer level, but also then as an employer, increasingly the premiums that keep coming up. And then we think about the government programs and how much we're using, and the fact from an international standpoint, we spend so much more than some of our other colleagues in developed countries. So since this is about workforce, I brought my own prop here, and that is, I think all of you know this book, and if not, please do have a chance to do this, review this, because this is a book that was assembled back in 2008 by the Institute of Medicine, when back in 2005 they really recognized how important it was to think about the workforce for an aging society. And so this report came out at that point. But as you think about it, the recommendations really have not changed in terms of what needs to be done. So they're really certainly salient today. But as 8 years have already gone by, the urgency is even greater. This is one slide that many of you know quite well. I think the two emphases I have is looking at the aging demographics that in this chart starts in 2015 and goes to 2060. And when we look at the younger population, last night I took a taxi from the airport to the hotel, and it was a pre-nursing student I met who was driving the taxi. And so he said, he was in school and he was getting ready for nursing, and I was delighted. He was an immigrant from India, and he said that one of the areas, I asked him what area he wanted to think about going into, and so he said pediatrics, and I'm knowing this line in the back of my head, and needless to say, I am rabid about recruiting people for our field, and I said, there'll be a lot of opportunities in this particular area. In fact, he's starting at a junior college because of affordability, and I said, be sure to kind of not stop there, but to keep going to make sure you have at minimum, your baccalaureate degree. And so we had a really nice chat, but I was hoping to recruit. It gave me a flashback. For those of you of a certain vintage, you'll remember the movie Dustin Hoffman was in The Graduate, and there was one word that somebody said to him, and they said plastics. So my one word is geriatrics now. So anyway, but he said, that he really hadn't thought about it, and he realized that there are a lot of people in nursing homes. So I also said, there are other positions that you can do in addition to nursing homes. So hopefully we will have a recruit. So the other aspect that does affect us tremendously is our realizing, and probably in many personal relationships, my mother-in-law had died from Alzheimer's, but the rate of this kind of growth and with the age demographic, and knowing that anywhere from 40 to 45% of us who reach the age of 85 will likely have the risk of this. So this begins to show, I marked for 2016 where we are in terms of the different age bands. The green age band, of course, is the younger, older population from 65 to 74. The purple is the population from 75 to 84, and then certainly the growth of the 85 plus. So this is the blessing as well as a challenge, and so the question is, who will care? And later on, I actually have some segment on caregivers, which is a real important aspect of really understanding. My geriatrician colleagues know this slide painfully well, and at this particular time, where we are is that there are under 4 geriatricians for every 10,000 older adults. But if you look at that same pattern over time, the irony of the slide previous with the population going up, the geriatrician number is going down. Right now, on AGS's website that we have, there are just under 7,500 board-certified geriatricians, some in allopathic medicine, but bottom line, 7,400. And the numbers are even painfully worse for geriatric psychiatrists. There are just over 1,600 certified geriatric psychiatrists in the whole country. And as we know, the cognitive issues, the issues of depression and anxiety and more comorbidity issues with psychiatric conditions. This is painful to realize. The next slide is relative to nurse training in geriatrics. This comes from an article that another colleague and I did back in 2011 when we looked at some of the population of the other professionals besides physicians. And at that point, fewer than half the schools in the School of Nursing had full-time faculty. Another third of the schools had part-time faculty. And in nursing curricula, very rarely is there much more than 25% of the content that is really focused on some of the complexities of older adults, comorbidities, and geriatrics. And it's painful because this is amazing, and I've raised this before, having taught at 3 universities. We have full curricula that's based on pediatrics, understood, full curricula that's based on OB-GYN. And the whole aspect of everybody sprinkling aging throughout the curriculum, frankly, is not sufficient in the way that we do it now. So faculty development is supposed to be fostered, and I'll give you an update in another slide about where we are today. The other disciplines include the pharmacists and social workers. And as of this article, there were only just over 1,200 certified geriatric pharmacists. This is one of the things that I have said that it is so crucial. When people have called me about, I think all of you know something about aging and geriatrics, get calls from your friends all the time. So I certainly get lots of calls and become a friend care manager for people. And I said, get yourself, it's hard enough to get a geriatrician. I said, but see if you can find a geriatric pharmacist, because that person is absolutely crucial in terms of helping sort things out. And but what has happened now, as you all know, that pharmacy continues to evolve with putting out pharmacists, but now the retail chains are snapping them up quickly, as well as the some of the ACOs are beginning to call upon people. And then social workers. It was just amazing that only out of the nearly 40,000 licensed social workers, only 12,000 had something to do with aging. So where are we today? And what I probably know best is the whole area of nursing, as I was also involved with the Institute of Medicine report on advancing change and in nursing leadership. As of 2008, one of the things that has been of a great loss to people who were focusing on geriatrics as nurse practitioners was the fact that the nursing world of licensure and certification decided to do away with the specific geriatric nurse practitioner role. And the goal was noble insofar as trying to make sure that it was broadened, that all adult nurse practitioners would have some aging. And so, like anything else, though, as many of you know, when you have comorbidities, you have cognitive issues, you have functional issues, there is a point where having a specialist is really very important. So that, frankly, has gone away. That is a fact. And now, within the nurse practitioner world, there is the designation of a certified nurse practitioner, and they have a pediatric one, and now they have an adult/gerontology certified nurse practitioner. And their training is a little deeper in it, but it's still, frankly, for those of us who understand what's coming upon us, we sense it's still quite thin. And so this is one of the areas of, having specialized knowledge is helpful. Foundations have been pitching in after the report from the IOM, this one here in 2008, so that the John A. Hartford Foundation, that has been renowned for its support for workforce infrastructure, especially geriatricians, social workers, and nurses, has funded this area quite extensively for quite some time, but as of 2012, they were one of the few left. The Hearst Foundation also funded some training for nursing faculty. So again, a 3-year grant, so there are a few more people in training, but nevertheless, again, you begin to feel how thin the infrastructure is. So as of 2012, fewer than 1% of the nurses in the country and fewer than 3% of the advanced practice nurses, say the nurse practitioners and those who are clinical nurse specialists, had any specialization in geriatrics. One thing that has evolved, which is good news, and I think Rochester General Hospital was one of the leaders in this, there's a geriatric center of excellence at NYU, and they have developed this program called NICHE, which is Nurses Improving Healthcare for Health System Elders. And as of this year, 680 hospitals and healthcare facilities throughout the United States, as well as 3 international countries, Canada, Bermuda, and Singapore, have actually taken this on so that acute care in particular, that's where they started, is a lot safer by having nurses more formally trained and skilled and knowledgeable in this area. And then the ACA, when it was passed, it actually started moving some options for having greater numbers of not only FQHCs, the federally qualified health centers, but nurse-led clinics. Now the next slide is really interesting. This is the FTC, and this gets into a more marketplace approach to this. One of the recommendations that had come out of the 2010 nursing report from the IOM is to start looking at trade barriers, so to speak, or market barriers for what licenses are about. And so this policy paper was developed in 2014, just about a year and a half ago. And the key line here after it says the context of looking at advanced practice nurses in the scope of practice, looking at it from a consumer safety perspective. The highlighted, italicized comment is, we reach the same conclusion. Expanded advanced practice registered nurse scope of practice is good for competition and American consumers. So what's interesting is that after some ability to look at this differently, because a lot of the nursing report did things that were good, but what I would call standard, and that is increase the number of nurses who start with a baccalaureate degree, make sure they're more PhD, doctoral level nurses for faculty, getting nurses to be part of teams, getting nurses on boards and all. But one of the things that was built into that report, and it was interesting, Dr. Troy Brennan, who is the Chief Medical Officer of CVS, was on this report committee. And he looked at it, of course, from a marketplace perspective, because their clinics that they have in their CVS programs have nurse practitioners as a part of it. So he had come up against the barrier of going state to state and finding these particular issues. And one of the recommendations that I recall that he actually had made was this FTC recommendation to take a look at it. So 4 years later, the FTC did do an extensive review and come out with a policy paper. And I also know that just this last month, West Virginia's legislature was responding to this with a comment paper that was written specifically based on the policy piece from FTC. So the FTC actually wrote the legislature in West Virginia to really advance this. So, and this is not only about nursing. More is happening in the areas of pharmacy as well as in dental care. North Carolina has a very famous case where the dental society actually precluded dental techs from doing whitening, teeth whitening. Now, you and I know as consumers, you can go to any retail drugstore and get whitening strips and to do this, but this becomes a barrier of practice in many areas, and the pharmacists are facing this too, because a lot of them are doing this, giving injections and for flu vaccine and all of this. But there's a great deal of push, and we'll be talking about that in a bit. The Brookings Institute actually came out with a paper on the issue of licensure as social mobility barriers. So if you are looking at that from an economic development perspective, that's something that you should look at to say, they fully acknowledge, consumer protection is absolutely important, but they went underneath it and took a look at it. Those of us who are, the licensure percentiles in different countries, in different states varies tremendously. In Iowa, the licensing, I think the licenses that are there are of the credentialed people are about 25%. South Carolina is 3%. And then when it comes to even manicurists, Iowa has 160 hours of training. For New York, it's half that training. So you begin to start seeing, if you really step back, the unevenness of this and the fact that there are economic barriers that actually disallow people from going from one state to the other. You certainly, if you already have a practice license in one state, and you don't want to go to a higher practice state unless you are willing to start going, paying the fees and doing this. So it's an interesting commentary of stepping back for a moment with all points even relative to consumer safety. And so this is something that, from a marketplace perspective, we should be looking at. So the next slide is one that comes from the Bureau of Labor Statistics. And this begins to talk about what the job outlook for aging physicians are in the future. And this ties so nicely to the taxi cab driver I was speaking to. The first kind of silver bar of money talks about the average wage in the United States, and it's just under $27,000. And then they list these different positions that have a specialty in geriatrics as to what one can earn. So you have over $42,000 for that first bar with a recreational therapist, to somebody who's a health services manager who makes just under $90,000. So this comes from the again, the Bureau of Labor Statistics, to show that there is a marketplace there, but the whole issue of why people don't go into this is very deep and complex. In fact, there's a woman who wrote in the Washington Post about 2 days ago, and she said, there's been the isms that we've been addressing, racism and feminism and issues of that nature. Why don't we talk about ageism, which is something that affects all of us? And so this is one of the isms that is being dealt with, and I know that American Geriatric Society has teamed up with 7 other organizations to really think through this issue of why, we've been kind of pleading, hoping people go into aging or geriatrics and geriatricians. There's some monetary components to it, but that's not the issue that precludes people from going into this area. But there's a level of ageism that is so significant that it just permeates. And many people actually, again, if you look at it objectively, their older adults are part of what's called now the longevity economy, that there are more people contributing to this. AARP has done some significant work to begin to put the dollars and cents of what a positive economic component this is that people aren't looking at. So it is the ageism, and it's how we talk about aging. And so I look for, apparently she has a book that's coming out pretty soon, but there are some more scientific work that is being done right now by ARP, the American Society on Aging, Geriatrical Society on Aging, on this whole aspect of what is the science behind all of this. And so we've employed anthropologists and other social scientists to begin to do this, and they're working now on different metaphors to talk about aging. Because we've heard about some of the talk about, elderly, senior citizens and all this. Those are terms, but they also say different things. So there's some really good work that should be coming out in this next year about the metaphors and the framing of aging that will address a great deal of this.